welcome to your online lecture for pathologies of the knee joint. As you can tell, this kind of been the sequential progression throughout the course. So we started with the foot and the toes and the ankle. We progressed to the lower limb, and now we're moving up the chain to the knee. I'm going to assume that in gross anatomy, you've had at least a foundational approach to discovering the knee joint, but I kind of want to make sure that we're all on the same page, at least in this class, regarding the knee and what it's actually made of in terms of the anatomical structures. And so just to start proximally, we have the articulation of this distal femur with the articulation of the proximal tibia, right? So we have the tibial femoral joint is its name. You can call it knee joint most certainly, but on your exams it will be referred to as the tibiofemoral joint. And so we can see that these two bones come together, right? And that's why it's called a joint. It's because it's the articulation between these two bones. A lot of times I used to assume that because the fibula articulates with the tibia, that in essence the fibula is a part of the tibiofemoral joint. But the research has suggested quite the opposite, that the fibula is a free floating bone and has no articulation with the femur. And so it's not really included in the discussion of knee joint pathologies. It's most often included in the discussion of lower limb pathologies, if that makes sense. So going back to the tibiofemoral joint, we have these two bones articulating and working together, right, to create knee flexion and knee extension moments and rotation moments about the knee joint, right? And then in between the two bones, what we have are the menisci, right, or the meniscus, if we're saying that singular. And the major role of the meniscus, which we'll talk about when we get to injury to those meniscus, really is number one, to prevent friction of the two bones as they articulate with one another, but then also to absorb shock as it's being transferred from that lower limb to the femur, right? And so these anatomical structures are extremely important because if they get torn or if they wear away, then essentially what you get is bone rubbing on bone, which is never a good thing, right? It's going to generate pain. And so we think of the knee joint as a hinge joint, right? Like if I were to go and open my office door, you would open that office door because it's on hinges. It's allowed to move in basically two essential directions, right? To open and to close. The knee joint is very similar that way. In essence, it moves into flexion and extension, right? That's what makes it a hinge joint. But we certainly have the opportunity to have rotary movements at the knee as well. So today we're going to cover the pathologies of the knee. Please note that I won't cover every single pathology because the purpose of this particular course is just to prepare you with the most common injuries that you're going to see in the clinical setting. Our lower extremity evaluation course will go into more detail and will cover other pathologies that are not included in this lecture. So if you know of knee pathologies that we haven't covered, sit tight. In the fall, I promise you we'll probably cover more knee pathologies than you actually want to know about. So our first stop is going to be in the area of the collateral ligaments. And so when we're talking about collateral ligaments, what we're talking about are those ligaments on the outside or external component of the knee. They are the ligaments on the external structure of the knee that are really going to hold the fibula or the tibia and the fibula to the actual femur itself, right? And so let's take a look at that. If we're looking medially, right? We're medial because we know that the tibia is the larger bone. So if we're looking medially at this MCL, what we'll see is its distal attachment is to that fibular flare, and then its proximal attachment is to the epicondyle of the femur, right? And so we have this particular ligament, which is really responsible for maintaining medial side of the knee stability. And then on the lateral side of the knee, we have the LCL, which is much smaller in both its length and its girth than the MCL, and we'll talk about why in just a second. But the lateral collateral ligament has a distal attachment to the fibula, and then it has a proximal attachment to that lateral epicondyle. And so you can see how these two ligaments are important for both lateral stability of the knee and medial stability of the knee. And so as we talk about how they're injured, let's just look at the anterior aspect of the knee, right? Let's orient ourselves just a little tiny bit. Superiorly or proximally, what we have is the quadriceps tendon. And then this entire structure would be called the patellar tendon, right? And so we're looking at this from an anterior perspective, right? So if we're thinking MCL and we're thinking about, well, how does that MCL actually get injured, right? What we know about MCLs is that most often they're injured when a blow to the knee is lateral, right? So when there's a lateral blow to the knee or a blow to the outside of the knee. such as in wrapping when you're trying to tackle, let's say, a running back would be an example of that. But an athlete either takes a blow to the lateral side of the knee, and essentially what happens is that knee does something like this, where the femur actually moves away from, you see it? Moves away from the tibia. And so you get that stretching, do you see it? Of the MCL, right? And that is known as a valgus load. So if I take a blow to the knee and that causes a stretching of that MCL, that is what's called a valgus load. So the mechanism of injury for MCL injuries is going to be a valgus load. That valgus load most often happens as a result of some kind of contact to the outside of the knee. Now, if we wanted to know how the LCL gets injured, then it's the opposite of that, right? There has to be either a blow or a force to the medial aspect of the knee that causes what? A stretching of the lateral collateral ligament, right? And that blow or that force that causes the stretching is called a varus force, right? So for recap, these ligaments are very strong, resilient structures. However, the injury can occur to them. If injury occurs to the MCL, most often there's a blow to the lateral side of the knee, which causes a stretching of that MCL. And that force, right, is called a valgus force. If the blow is to the medial aspect of the knee, right, and it stretches the LCL using a varus force, then we have an injury to the LCL. And so we can see how forces on either side of the knee can cause injury to our collateral ligaments. Major role of these collateral ligaments then is what, you guys? Good. I'm hoping that you said it's to provide stability, right, in the frontal plane of motion, right? So their major role is to provide stability in the frontal plane of motion. So if there's injury to either of these ligaments, then essentially what you have, the concern is instability as your patient is doing those side-to-side movements, right? Okay, so as we progress, let's take a look at an example. So in this particular PowerPoint slide, what you see is mechanistic injury A, and you have mechanistic injury B. And so if we look at this, we're saying, okay, let's orient ourselves. This is the lateral side of the knee, and this is the medial side of the knee. The blow or the force is happening to the lateral side of the knee. It's a valgus load, right? Valgus force. Therefore, what we know is that MCL is going to get injured. In image B, what we see is that there's a force being applied to the lateral side of the knee. If a force being applied to the medial side of the knee, medial, right? And so as a result, that LCL gets injured because that's a varus force or a varus load, right? And so we can see how this can happen. We can see it happen a lot with contact sports, but we certainly can see it happen in a non-contact mechanism. In other words, that athlete lands differently, and as a result, there's just more load on that lateral side, and so the MCL gives way. And we'll talk about this a little bit more when we get to ACLs as well. So let's talk about the signs and symptoms of an MCL or LCL injury. So what we know about these injuries is a couple things. So if we're looking at a ligament, let's go with the LCL. There are 3 different areas in which a patient can be tendered to palpation. The first one is if the injury happens to the distal attachment site, right? So that patient's going to be tendered to palpation on its distal attachment. Certainly could have an injury that causes a rupturing of the mid-substance of that ligament, so they might be tendered to palpation right in this sweet spot right here, which we call the joint line. Or it could be that you have a proximal tearing of the proximal attachment, and so their palpation to pain or tenderness to pain will occur right at its proximal attachment site. So there's 3 areas that we really have to palpate when we're assessing a ligament for pain, right? So we certainly could start here and they could say, nope, no pain, and we could finish our evaluation. The reality is we really want to palpate all of the structure to see where, in fact, the injury to the ligament has actually occurred. We also know is that if there is a mid-substance tear, right, so right in the middle of that ligament, most often the swelling will leak into the joint line. So let's take an anterior position. If I have a tear here, what you're going to see is that the fluid is going to leak out into this joint line space here. So not only will you have tenderness to palpation on the lateral side, but you might also have some like pooch swelling or pouch swelling right here on the anterior lateral aspect of the knee, which would create what's called a joint effusion, right? In other words, when you touch there, you'll feel lots of water within the knee. And then the most telltale sign that a patient has compromised their ligament is through laxity testing. So there are two tests that we use to rule in or rule out an MCL or an LCL sprain. First test is known as a valgus stress test. So what do you guys think? If I'm using a valgus stress test, which ligament am I testing? Yeah, so it's going to be the MCL. So just imagine this. Here's my patient lying on the table. Let's do it this way since I'm testing MCL. I am going to create, guess what? A lateral force which stretches the MCL, right? And if I'm a tight MCL, when I apply that force, guess what? That joint shouldn't open, right? If I'm a loose or lax MCL, then when I open that joint line space, you're going to just see what? Lots of instability at the knee, right, guys? The same thing applies when I'm applying a varus force, right? So the force is coming from the medial side to the lateral. And if I have an injured LCL, my joint line will just keep opening and opening and opening and opening. However, if my LCL is intact and it's not compromised, then when I go to create that varus force, I'm going to get very little movement away from the femur and tibia. Does that make sense, guys? Hope so. We'll do it in class eventually, but just be thinking about that. One of the telltale signs of an injured ligament, collateral ligament, is laxity, looseness, as you go into either a varus force here or a valgus force for the medial side of the knee. All right. And so I've described that test in the other slide, but you can see it here. If you're more of a still visual person, this is a valgus load being applied. Therefore, we are testing the MCL. And then this is a varus load being applied, right? Because what do we see in this image? We see the clinician's hand on the medial side of the knee, which means we're applying a laterally directed force, which would do what? It would rupture the LCL, okay? Now, we're going to talk about ergonomic position of the clinician. This is a terrible position for you to be in. Number one, with a 300-pound lineman, the reality is you would hurt your back if you were in this position trying to hold up that lineman's leg. So we'll talk about good ways to use your body, your hips, etc., to help you navigate these collateral ligamentous sprains. In terms of management, there are a couple things to consider. Number one, the MCL is injured more often than its LCL counterpart. The reason for that is twofold. Number one, the majority of forces to the knee are most often going to occur to the outside of the knee. In other words, the outside of the knee is just more exposed to forces. And the other reason that it's often injured is because what we know anatomically about the MCL is that it's deep. We're talking deep fibers attached to the medial meniscus. So it's injured more often because if the meniscus on the medial side gets injured, most often those deep fibers do too. But then also because we have more exposure to the lateral side of the knee, which means more valgus forces, which means more injuries or compromise to that MCL. Okay. LCLs tend to be a little bit tougher to treat. And the reason for that is because of what it says on the slide. They're less it's less vascular, which means because it's not getting as much blood flow, right? Then it takes a lot longer to heal itself, sometimes requiring surgical intervention. It really just depends. Whereas the MCL, on the other hand, attaches to that medial meniscus. And remember, or you will remember in just a second when we get to the meniscal slides, that on the periphery or the outside of that meniscus, what we see a lot is that it's vascularized. So the MCL will essentially, by way of the meniscus, at least get some blood flow. And so it tends to resolve itself and heal itself a lot sooner than an LCL sprain because of the lack of vascularity with the LCL on the lateral side of the knee. So in terms of its treatment or its management, it's actually pretty simple. It's going to be that price. So we're going to protect that patient by kind of splinting them into a knee extended position. And by doing that, just think, if they're in an extended position, then essentially what we're doing is just taking off the workload of that ligament. Because as soon as we flex, what happens to that ligament? Are you guys seeing it there? There's going to be a stretching that happens, right? So if we lock the knee joint into extension, essentially what happens is that ligament is allowed to rest. It's allowed to heal. Its fibers are allowed to tack down. If we allow that patient to move in and out of knee flexion, then essentially what we see is a ligament that might heal in a lengthened position or doesn't tack back down to its shortened position, right? And so where we can, of course, if we're in the midst of football season, we're certainly not going to lock that patient into an extended position. But where we can, we want to protect our patients, right? And if we can do that, if they're out of season, then certainly locking them into extension for a week or so will at least allow those fibers time to heal themselves, to tack back down into a shortened position, right? Okay. Most often, there's non-surgical intervention required. The caveat to that would be if, in fact, the MCL injury is associated with a meniscal injury, right? Because then we're probably going in internally to repair that meniscus. Last but not least, one of the things that we have to consider with an MCL rupture in particular is that if they've ruptured their MCL, probably have compromised their meniscus, the other pathology that we want to rule out in the bigger scheme of things is probably the ACL injury, right? And so that's one pathology that we have to consider as we begin to evaluate these patients in our clinical setting. In terms of immobilization, it's kind of what I alluded to. We're going to put them in a hinge brace, which would lock them into extension. And you certainly could move the degree of allowable knee flexion as patient signs and symptoms reduce. The big deal is we want them limited in extension as much as is possible. All right, moving forward, I think this is probably what you hear the most when you're watching ESPN, when you're watching any other sporting event, is the ACL, the ACL, the ACL, right? For those of you who do not know, I'm assuming you all do, the ACL stands for anterior cruciate ligament. It is one of two internal ligamentous structures, right? Remember, we talked about the collateral ligaments as being those external structures on the outside of the knee and providing stability. And then if we open up the knee joint, right, then internally the two ligamentous structures providing the most stability to the knee are going to be the cruciate ligaments. We won't talk about posterior cruciate ligaments in this particular lecture. We will in lower extremity evaluation. For today, we're going to focus on just the anterior cruciate ligament. So what is the mechanism of injury for the anterior cruciate ligament? Are you guys ready? Okay, so it's a valgus load, one in which that MCL is going to be stretched. It's going to be external rotation. Are you guys seeing that? Coupled with a little bit of knee flexion, right? So let me do it again. Valgus load, external rotation, right? And what you'll see is that ACL gets pretty stretched. And so in terms of a patient coming into our clinic with a knee pathology, the first thing that I ask is, can you tell me what happened? Can you tell me in which direction your knee went, right? Because if they tell me, oh, it went this direction, then I know MCL, right? If they tell me, oh, it just went like this, then I know LCL. If they tell me, oh my goodness, I did this and I rotated, right? Then I'm thinking has to be ACL. Does that make sense? So a lot of times, a lot of what we're doing and seeing in our clinic, we have to get to a point to where we're asking good questions, because if we're asking the correct questions, then we'll know which pathology that at least we're suspecting, right? So for ACLs, it's always, did you feel a pop or a snap? And then number two, how did you injure it? Like, show me on the other leg with your arm which direction your knee went, right? That will help you either checklist off some of the things that you think it was, and it will also allow you to know whether or not you're suspecting the ACL, okay? There are two mechanisms of injury for the ACL. Both of them happen the same way, though. It's usually valgus load, external rotation. But it could either be as a result of a non-contact injury, which means no one did anything to the patient, right? They either landed weird, they planted weird, and the ACL gave out. Or it certainly could be as a result of a direct contact, right? So, a slide tackle, a wrap, different ways that could happen. But most often when we're thinking ACL mechanisms, what we're really saying is that ACL typically happened as a result of the valgus external rotation moment, right? The question just becomes, did someone cause it, or was it as a result of the way that I landed or twisted or rotated, right? Okay. So let's take a look at a non-contact example. So in this image, what I'm hoping you guys will see, and it happens very quickly, is essentially this is a non-contact injury. Athlete plants, goes to kick, and then you can see that rotation moment, right? And it's beautiful. But the problem is, as athletic trainers, right, let's just think through this. As athletic trainers, I wouldn't have caught that, right? Because it was such a subtle mechanism, right? And those are the types of injuries that are going to come into your clinic. Well, I was just kicking a soccer ball, or I went to plant and my knee buckled and gave way. No one touches them, right? Another example of a non-contact injury would be this injury, which we see often in volleyball. So let's take step one. Athlete goes up to the net to spike the ball. Athlete's following through, comes down. Look at the load, right? So we see we have a valgus load at the knee, and we also have that external tibial rotation moment. And she's down, right? And ruptured ACL, end of the season. So let's talk about this from a clinical standpoint. One of the things that athletic trainers have started to do, and this has just started to happen over the last 5 to 7 years, is essentially what we've started to do is say, okay, part of the reason that females in particular are rupturing their ACL, some of them we can do something about. The intrinsic factors we can't. So, right, that would be menstruation would be an example, hormonal fluctuations. We can do nothing about that. We can't control that. But we certainly can control some of the extrinsic variables. And one of those extrinsic variables that's been reported as an increased risk for the rupture of an ACL is the amount of valgus collapse or valgus load that a patient exhibits upon landing, right? So if we're looking at this image here, what we'll see is this patient's going up to jump and then she lands. And what do you see here? Both knees are touching, right? Which is typically should not happen in a landing mechanism. And so the question becomes, how do we train this, right? How do we get a patient to jump up and land without falling into a knee valgus moment, right? And there are different ways depending on which strength and conditioning coach you ask, which personal trainer you ask, or quite frankly, what athletic trainer you ask, right? Some would say, well, it depends. Is it the glute med? Is it the trunk? Is it the hamstring? Is it the quads? What are we going to do? What I can tell you is that it's very patient specific, right? We have to look at all of the biomechanical kinematic factors and then determine for that particular patient standing in front of you which training program would be a better approach to help correct the valgus load, right? And so then we look at this single leg jumping task. Same thing. She jumps up and then she lands. I mean, look at that. You've got a pronated moment at the foot and then you have this valgus moment at the knee. So how can we control that? Can we strengthen the glutes to kind of help stabilize the femur on the pelvis? What do? I don't think at this point in your career, unless of course you're a strength and conditioning coach or a personal trainer, that you're equipped with the knowledge to know. But our goal would be that over time with these courses that you're taking, that you'd be able to, number one, identify it. That's first, right? If you can do that in the clinical setting over the next 8 weeks of your life, then that's a good goal to have. But as you progress through the program, our goal would be you'd be able to identify them. You'd be able to create a rehab program for them, right? Such that they would not be the patient who's walking into you with an ACL injury. And that begins with prevention screening for every sport that you work with. Okay, so in terms of ACL injury signs and symptoms, the number one reported sign and symptom from a patient is going to be that they felt a pop. So they'll feel a pop in the knee and they will have immediate instability. Now, listen to me here. With the collateral ligaments, that patient may very well be able to go on and participate and finish it out and come and see you afterwards, right? They'll have pain, but the amount of disability and instability that's present when an ACL gets ruptured, there's no comparison. In other words, the patient can't finish it out because the knee feels so unstable, almost like they're going to dislocate their knee, right? And so that is a sign and a symptom. But the biggest thing that they tell you is they feel like their knees coming apart. And that sounds so weird, but just think, here's that ACL. The major role of the ACL in the knee joint is to prevent anterior translation of the tibia, right? So let me do that again. I'm here. This is femur. It's to prevent this, right? And so if we're trying to prevent anterior motion of the tibia and that ACL is ruptured, could you imagine how much instability that patient is feeling if there's no ACL present, right? And so what we're going to do with these particular patients is we're going to have to do our clinical special test to determine whether or not they've actually ruptured their ACL. And I'll show you a few of those tests on the next slides. In terms of management of ACL ruptures, we're going to ice them and literally send them out for an MRI to confirm. And then I would say 98% of the population, they go in for some type of ACL repair. Now, with that said, there are 2% of the population who live in what's called a Coper category. And so what that means is they rupture their ACL, but their quads and their hamstrings are extremely strong and they can function without an ACL. I said that's 2%, so a very small percent of the population. Most often, most of these young men and young women are going in for surgical intervention. In fact, Copers are typically done with their athletic career and maybe they're moving on into a different life. They're a mom, they're a dad, and so they don't need the ACL as much as you do when you're athletically participating in a sport, right? So to be 100% transparent, not every patient who ruptures their ACL will undergo surgery, but in the athletic population, that's most likely going to be the case. It'll be a surgical repair. Surgical repair could be with a patellar tendon, a patellar ligament, if I'm using the right term, or we've seen the hamstrings being used as a graft as well. And there's contraindications for both, and we can discuss that when we meet if you would like. Okay, so I said there would be special tests that we'll talk about. The first of the special tests is the anterior drawer test. It's probably my least favorite clinical test to use, but it is the most commonly reported in the field of athletic training, and we're slowly moving away from that. But I wouldn't be doing you justice if for some reason I didn't talk about it. And so this is the anterior drawer test. As you can see, your patient's going to be lying in a supine position with the knee flexed to about 90 degrees. And your job as a clinician, number one, is to wrap your fingers around the gastrocs. Now, look at me here. I'll show you what that looks like. It's a here mechanism. I'm not gripping it hard. I'm just laying them there kind of like this. I would say hugging the gastrocs. Okay, you guys? And then essentially what you're going to do with those fingers is try to glide that tibia anteriorly, right? So I'm going to try to glide that tibia anteriorly with my fingers. And so let me show you what that looks like in the video that's attached. So here it is. So you've got posterior drawer, and then eventually in the video you'll see him pull forward. Do you see that? And so it's that movement right there, that anterior translation of the tibia, that is not normal, right, you guys? And this is a drastic patient, certainly a patient who had a complete knee dislocation and ruptured ACL and PCL. And so you can see, again, he's doing what's called a Lockman's test there. And you can see the amount of movement in that knee. It is not normal, okay, you guys? It is not normal to have that much motion within the knee joint, that much anterior motion within the knee joint, right? So then again, we're talking Lockman's test. And Lockman's test, the patient is actually lying down, which to me places them in a better position. And the knee is not in as much flexion when you compare it to the anterior drawer test. And so this knee position is going to be such that the patient has about 30 degrees of knee flexion, right? And so I'll show you what that exam looks like in this particular video. So knees at about 30 degrees of flexion, as you can see it here. You have one hand on the quadriceps stabilizing, and that hand is typically the hand closest to the patient's head. And then you have your hand right on the patient's knee. So we'll wind it one more time for you guys to see. You also see that the clinician is externally rotating that tibia, right? And so there's just a gentle tug of the tibia anteriorly, and the goal of that tug is really to see just how much that tibia is going to glide anteriorly. Now, this used to be the gold standard test for ACLs. It still tends to be the gold standard test. There's one more special test that we'll talk about in lower extremity evaluation, which is the Lely's test. But for now, if you're in the clinical setting and you're forced to do a special test, this would be probably the better of the two tests to do when you're comparing anterior drawer and the Lockman's test. And if you guys would like to practice that, let me know. We can certainly meet up and get some practice in. Okay, we're going on, or we're progressing into meniscal tears. Meniscal tears or impingement of the meniscus are a common pathology that you're going to see in the clinical setting. Most often you see this in your soccers, you'll see it in your basketball sports, certainly could see it in football, not as common as an ACL rupture, but certainly could. So what is the etiology? Quite honestly, it's any rotational force about the tibial femoral joint. So here's femur. Any rotation, can you guys see that? Any rotation will irritate, pinch, tear the meniscus, right? And so it's any type of knee injury or knee mechanism that involves rotation, okay? And obviously the patient has to be in a weight-bearing position. So essentially what we also see with that, as I mentioned in the MCL slide, is that the MCL can also get injured secondarily to a meniscal tear, specifically if there's a valgus force involved in the mechanism of the injury. But here it is, guys. You've got rotation. See the rotation happening at the distal limb, and then you could have a valgus force, right? Isn't necessary, but certainly does happen often, right? Okay, as we look at this image here, what you're seeing is that the menisci are shaped differently on each side of the knee. And so if we're looking at the medial meniscus, it tends to be a little bit larger in nature, and that's to receive the larger, guess what? The larger condyle on the medial side. And then you have the lateral meniscus, which is more C-shaped and smaller. And the reason that it's smaller is because the lateral condyle of the femur is smaller. So it makes sense that their size is kind of determined by the size of their bony prominence that they are receiving. Does that make sense, guys? Great. All right. So let's talk about meniscal tears. I think important, if I had to look at this checklist and if I were to say, well, what's a common sign and symptom that isn't common in the other knee pathologies that we talked about? The two that I would say are the intermittent joint locking. So in other words, that patient may be walking along fine, and then their knee gets stuck right here, gets stuck, and they may have to shake it out to make it move again, right? So I would say it's the intermediate joint locking, and I would say that it's that pain with squatting. And now, so I'm not talking about, so I'm going to stand up and I'm going to show you what I'm not talking about. So if this is a squat, we're not saying pain with that kind of squat. What we're essentially saying is that that patient has pain when they get all the way down into their squat position, right? So when we're talking about squat positions, we have to make sure that when we're testing that meniscus, that we're actually asking them to get into that deep squat, because it's in that deep squat, look at the posterior knee, that we're actually going to impinge that meniscus, right? If we're in the beginning phases of that squat, not going to happen. So they have to get down into a very deep squat to impinge those posterior horns of that particular meniscus. Okay, guys? All right. Now, as we look at the different tears, and of course, I'm showing you different tears that are most common, but there certainly are other types of meniscal tears that certainly can be present in our patient population. So what I'm going to show you are a list of the most common, but certainly there are others, right? You can have a radial tear, an oblique tear, a flap tear, and essentially what you can see is that oblique tear here probably progresses into a flap or a parrot beak tear. You can have just a straight longitudinal tear, and then that could progress into a bucket handle tear. And the worst kind of tear, quite honestly, is this degenerative kind of complex tearing, where the tear is occurring all the way through the most medial portion of that meniscus, right? All of these tears exist. You won't be able to diagnose them. The only way to diagnose them is truly through MRI or imaging. But what's important to know about these tears is that each of these tears kind of tell us the prognosis of our patient and the type of surgery that patient may have, right? And we're going to talk about when a patient actually has surgery and when they don't, based on zones of the meniscus. But essentially, management of the meniscus is really refer, get the imaging, and then we have to decide, are they going to repair that meniscus, actually suture it, or are they just going to cut it out and return that patient to play? And then your rehab depends on the type of surgery that the patient has. So let's progress to the next slide. It's one of my most favorite slides to discuss in class. And the reason for this is because I think this helps hammer home why we either repair a meniscus or why we actually cut it out instead of trying to sew it back together in hopes that it will regenerate itself. What we know about the meniscus is that the meniscus has an area where there is blood supply to it, and the meniscus has an area where there is no blood supply to it. So let's take a look at the bottom left-hand corner of your screen. The most peripheral portion of the meniscus, or the outside portion of the meniscus, right? So let's bring that home. This portion of the meniscus, that outer peripheral portion, is most highly vascularized. In other words, what I'm saying is it's this red zone, red because it gets blood supply. And we can see that here in this image. And this is why I love this image. So if you can see, we have the genicular arteries, which are supplying the peripheral components of each of the menisci, right? So let's think about that. We have genicular arteries, arterial blood flow going to the peripheral or most outer portions of the meniscus. So what does that mean? It means that they can be healed, like it can heal. So if an injury happens to the periphery, right, or the most outer portion of our menisci, then the surgeon's going to go in and they're going to suture that. And they're going to try to keep that tissue there, and they're going to try to repair it. Does that make sense? We have two other zones, however, the pink zone, and then we have, or the red-white zone, and we have the white zone, right? And if we look at them on this image here, what you'll see is what? There's not a lot of genicular artery supply. In other words, there's not a lot of blood flow to any other part of the meniscus. So most often, if a patient has imaging and if that tear is in that red-white zone or the white-white zone, then most often the physician says there's no need to repair this because there's no blood flow. We know it's not going to heal itself. And so they just snip, 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 cut it out. Now, there are advantages to both surgeries. If you have an athlete who needs to get back to play right away, they're in season, then a meniscectomy or cutting out that meniscus, the recovery rate is quicker. We're talking 7 to 14 days to return. If you have a patient who has a tear in that peripheral part of the meniscus and we repair it with sutures, then we have to protect those sutures, right? And if we protect those sutures, you're looking at 10 to 12 weeks of a recovery versus two weeks maximum for a meniscectomy. So there certainly are advantages and disadvantages. After being in the literature for the last 2.5 years and really truly studying the meniscal pathology, what I've learned is that we'll take those 10 to 12 weeks because what we know about the meniscus, you guys, what we know about them without a doubt is they are the major shock absorbers for the knee. And so as we begin to cut them out, as we begin to cut them away, what we tend to do is we're taking away our major shock absorbers, number one. And then number two, what we're doing is we're increasing the rate and the risk of that patient for developing osteoarthritis. Because now what we've done is take away this part, which is responsible for what? Keeping those bones from bumping up against one another. So it's twofold. Number one, we increase their risk of developing osteoarthritis. Number two, we take away the major shock absorbers of the knee when we cut out pieces of the meniscus. And are we saying that they're going to develop osteoarthritis in a week after the surgery? No, we're talking 10 years out. But we care about our patients. I hope we do. We care about them enough to say, what are the long-term consequences of the things that we are doing now? If you aren't thinking that, I challenge you to always think that way when you're treating a patient. So let's take a look at the next slide, because this slide kind of hammers home what we've already been talking about, right, you guys? This idea that, in fact, you're going to see different types of tears. And so then the question really just becomes, how do we manage that, right? So what do you do? If you're a surgeon, do you repair this or do you cut it out, right? And the question's going to be, well, is it in that peripheral zone or is it in that pink, red, white, or white zone, right? If it's in the white zone, we're certainly cutting it out. If it's in the red, white zone, then we might try to repair it in hopes that we can keep that cartilaginous structure intact, but you might have a risk of failure, right? And then you cut it out. So then the question just becomes, what do we do once we've either decided to repair it or we've decided to cut it out? And that's where you as athletic trainers come in, right? Your job then is to rehab them. It's to strengthen all of the stabilizing structures around the knee, the quadriceps, the hamstrings, the glutes, the adductors, the abductors. Should I say everything there? Your job is then to rehab that patient so that the same thing doesn't happen again. And so here's an image essentially of surgery, right? So that physician's going in with a clean tool and you can see the fraying of that meniscus here. So they're going to go in and clean that out so it looks smooth like this part of the meniscus here. Okay, now we're kind of getting into some, I guess, traumatic injuries to the knee. We'll talk about a total knee dislocation. One of the most traumatic things that you'll probably see in the early weeks of fall clinical rotations really will be a bursitis. So with a bursitis, what you're saying is it's an itis, which means what? It's an inflammatory response. And so then what is it an inflammatory response of? Bursa. And so what are bursas? Essentially, what we're thinking about bursas, they are the protective sacs of the knee. They are like water balloons that sit in very important places. In the elbow, we have a bursa here. Why? Because it's a bony prominence. So in the knee, the bony prominence that we are trying to protect with our bursa is typically the patella. And so we have 3 bursa. There are more in the knee, but the 3 that I think are most important for you guys to know right now. The first one is the prepatellar bursa. So the prepatellar bursa sits just posterior or deep to the patellar tendon. Okay, so this tendon is structured here, and it sits above the patella itself. So you can think about it deep to the patellar tendon, or just above the um, the patella itself. So imagine like if we were to bend our knee and fall on the ground. Has that ever happened to anyone? Okay, I'll admit it's happened to me. So like if you fall directly to the ground on your knee, most often you would expect the patella to rupture, but it doesn't. And the reason for that is because of our prepatellar bursa right here, right? You can see it. It's deep to that patellar tendon, and it sits just on top of the patella. And its major role is if the patella makes contact with the ground, it's going to like blow up, right? And if it explodes or if it gets inflamed, then essentially that's a good thing, because what it means is it protected that patella from rupturing, right? We have other patellar bursas. The one down here is called the infrapatellar bursa, because a lot of times, let's think volleyball where they're diving. In particular, our liberos are diving on their knees a lot. This particular bursa will become inflamed. And then last but not least, we have the suprapatellar bursa. I have yet to see this in clinical practice, but certainly could happen as a way of irritation of that quadriceps tendon here proximally. Most often, though, you guys, I see prepatellar bursa and infrapatellar bursa. What's that mean? It's inflamed, right? So let's talk about the etiology. Most often, in terms of mechanism, it's some type of direct contact to the anterior aspect of the knee. We see this in professions that require a lot of positioning on the knee. So it used to be called housemaid's knee because a lot of cleaners will be on their hands and knees scrubbing the floors of the houses they clean, and they would present to the emergency room with knees that looked like these images here, right, on the slide. And so then they started calling it housemaid's knee. But the reality is there are other sports that we see bursitis happen often in the knee joint, in particular volleyball. Volleyball is like our number one heavy hitter for prepatellar and infrapatellar bursa, and it's because they're doing so much diving, so much digging, right? You guys have seen the sport of volleyball, so you realize that the knees. That's why they almost require knee pads now, right? Because the knees suffer from so much trauma. But there certainly are other sports where this could run rampant. But volleyball by far is the number one sport for a bursitis. In terms of signs and symptoms, I think it's pretty obvious when a patient walks into your clinic with a bursitis, right? Most often you're going to have massive amounts of swelling about the knee joint. The hard part is when you have swelling at the knee joint, you want to make sure you rule out your most common injuries, right? So you want to rule out ACL, you want to rule out meniscus, right? You want to rule out collateral ligamentous injuries. And then finally, the most obvious would be the bursa. But the first thing that you want to make sure of is that they didn't injure any of the either external ligaments or the intrinsic ligaments of the knee. And once you've done that, then you're left with the most common pathology that it could be, which is bursitis. So in terms of management, you're going to see the management down here on this slide. It's literally aspiration of the knee in most instances. What physicians will recommend is first trying to allow the athlete's circulatory system or lymph system to resolve the fluid or the swelling. So they'll recommend patting it, elevating it, and then if that doesn't resolve itself within 2 to 3 days, then they might go in and do something here. They'll aspirate it. Now, the cool thing about the college rotations or working with the colleges is most often you'll go into doctor's clinics and you'll be able to see this. They'll go in, they'll drain the area, and then the knee will be back to normal, right? If the injury was as a result of trauma, then certainly you're probably dealing with a contusion or two that needs to resolve itself. But for the most part, if it's a spontaneous bursitis, meaning there was no trauma, then you aspirate and then you let them play. What I would say is that if you notice that an athlete is coming in repetitively with bursitis, then the recommendation is most often to pad them, right? A volleyball knee pad, for example. Even if it's not in volleyball, that athlete still wears it if they're falling on their knees a lot. Basketball would be an example of that, where you have athletes who are just extremely clumsy, and so you have them put on knee pads because they get bursitis because they're falling all over the place. And then NSAIDs, most often those are going to be prescription based, but they certainly could be over the counter. So your ibuprofens, your Motrins, and or your Aleve. Okay, the next pathology that we'll talk about is chondromalacia. In my least favorite term, because it is a generalized term for just knee pain, right? So what is malacia? Essentially, it's softening of the patella. So essentially, if we're looking at this, what we're saying is this blue part right here articulates with the femur here, right? So imagine that system. The knee, the tibial femoral joint, and the patella work together, right? And during these processes, what we see is that when the knee's in extension, the patella kind of moves inferiorly, and as we move into a knee flex position, that patella is gliding superiorly on the femur, right? So essentially, that bone is probably going to wear away, right? This backside of the patella probably is going to wear away a little bit and start to soften. And so that's what chondromalacia is. Chondromalacia is essentially a wearing away of the backside of the patella such that it doesn't move or glide as smoothly. And so when it doesn't move or glide as smoothly, then what you see is it starts to incite or elicit pain within the knee. What's frustrating about chondromalacia most often is that the etiology or the mechanism of injury is unknown, but what we know most often is that it's linked to some type of abnormal tracking between the two bones, between the femur and the patella. Does that make sense? Either that patella isn't gliding as superiorly as it should or inferiorly as it should, and so it's spending more time rubbing on the femur. And so we'll dive deeper to that in lower extremity. For now, signs and symptoms associated with chondromalacia are going to include general knee pain that doesn't resolve itself, right? So you as a clinician, you're going to have to kind of do a biomechanical analysis. You're going to have to assess patient's gait, which we'll learn in lower extremity analysis. You'll have to assess not only their gait, but their foot posture, right? So all of these things that we're talking about from lecture to lecture will come into play with chondromalacia. In terms of management, the biggest thing that you can do for this patient is manage kind of the symptoms if you can't get to the biomechanical analysis. And you want to limit the following activities. So stairs and squatting, because what we know about stairs and squatting is particularly as they squat, what we know about the amount of load being placed on that patella is it increases. So we want to decrease load on the patella. We want to decrease the amount of movement that's occurring across the patella and the femur. And so we do that by limiting stairs because, number one, that causes a lot of knee flexion, and squatting because deep squatting will increase the amount of forces across the patella and the femur, okay? So we want to limit that where we can. But if you're at a campus that has stairs and heels, then there's not quite much that you can do except for maybe putting that patient in a knee brace to kind of help them get through, or putting them on crutches, right? Which isn't ideal either for a Healy or a stair-based campus. And then, like every knee pathology that has swelling, so bursitis, for example, NSAIDs are going to be good to reduce the inflammation and strengthening. And if nothing else, what I have seen done twice in my runners is the physician, if nothing else works, they'll go in and start and shave down the backside of the patella to get rid of the softening part in hopes that we will have a good articulation or restore articulation across the patellofemoral joint. Okay, the patellar luxation is just as the name implies, it is a dislocation of the patella. Most often in terms of mechanism of injury, the patient's foot is going to be planted. They're going to be cutting in the kind of opposite direction. And so what you'll see is exactly what you see in this image here is that patella will usually luxate laterally. Okay, so there is a luxation, and that luxation or dislocation is happening laterally. You also could have a direct blow to the medial side of the knee, which causes the patella to luxate as well or dislocate as well. And these are very common and probably will happen as you enter into your clinical rotations. And so pathology-wise, what we want to look for is, number one, as they dislocated out of their knee joint, right? So imagine that I'm dislocating out of my knee joint. So when I dislocated, did I injure any of the bone on the backside of the patella, number one? And then was that injury enough to cause like an actual fracturing of the bone such that a piece of the bone broke off? And then last, but certainly not least, and probably most important, as I shifted laterally, did I stretch all of the retinacular structures that are holding my patella in place, right? Those are things that we want to assess if possible. Okay, so let us see if I can get this video to work for us and play for us. Essentially what we're looking at, is going to be like a patellar luxation in
Flat
real time.
dislocation.
And so you can see that here, right? So look at that, right? You shouldn't be able to, do you see it? You shouldn't be able to move the patella that much and glide it that much. And so you can see like it's luxated, it's stuck, and I'm assuming he's going to pop her back into place, right? And that's obviously a lot more traumatic than we would like it to be, but essentially at least you get to see real time what that luxation looks like and what it would present itself like in the clinical setting. Okay, let's move forward. In terms of signs and symptoms, I think these are pretty straightforward, guys. It's really observation. Most often, what you're going to see if the patella is still stuck in that position is a gross abnormality or deformity of the patella sitting more laterally. But certainly, if it has relocated itself, then that patient's going to present to you with a lot of anterior swelling or effusion in the knee. Will have pain. Most often, they're going to have pain with it's usually the flexion moment because that's going to stretch all of the tissues, but they'll be limited in their motion, their range of motion at the knee joint. Because why? They just had a massive trauma to the knee, right? Just imagine that. If you ever dislocated your patella, then you know. I just stretched all of the tissues on the medial side of my knee. So the last thing that I'm going to want to do is do what? Stretch any of the tissues. In terms of management, the management is going to vary and depend on the number of tissues that were damaged during the initial dislocation. So if the patient is still dislocated, then the first thing they're going to do is relocate that patella. That's first and foremost. It sounds easier said than done. I've seen this done in a patient who was conscious. And their problem is that their quadriceps are contracting forcefully, makes it extremely difficult to relocate that patella. So sometimes they actually have to give that patient a sedative to make the relocation less traumatic. But then we're going to immobilize that patient. Most often that patient's going to be immobilized in a knee extended position. Why? It's similar to what we just talked about, right? Is the idea that with our collateral ligaments, we don't want the stretching of the tissue. So often we'll lock them into a knee extended position with the goal of allowing that tissue to calm down and rest, right? And then after they're healed or feeling better and we can improve and work on range of motion, then you certainly want to start strengthening both the quadriceps muscles, but then posteriorly, you want to strengthen the hamstring muscles as well. All right. IT band syndrome, also known as runner's knee. Please call it IT band syndrome or iliotibial band syndrome. As you can see here on this slide, occurs to the most distal component of the IT band. So it's the knee portion of the IT band, not the hip portion proximally. Most often is caused by some type of repetitive overuse. And it is linked to some type of kind of malalignment. That malalignment could be several different things. It could be a patellar malalignment. It could be a pelvic malalignment. It could certainly be a spinal malalignment as well. And it could also be as a result of foot biomechanical differences. So a patient who presents with a pes planus or a pes cavus foot could certainly have knee pain as a result of a tight IT band. So there are lots of different ways in which a patient can present to you with iliotibial band friction syndrome, right? So the signs and symptoms are going to be pain right at this most distal portion of the lateral kind of knee. So number one, right at its attachment to Gertie's tubercle. But certainly they have a lot of pain in this lateral condyle region as well, in particular with knee flexion and knee extension moments. And so you want to palpate both here on the lateral side of the femur, but you also want to palpate as it progresses down onto Gertie's tubercle as well. What we also see a lot of times with IT band tendinitis is that patient will sometimes, as a result of a pes anserine tendinitis and bursitis on the medial side of the knee, will sometimes substitute. Does that make sense? And as a result, it can also cause an iliotibial band tract irritation. So we really just have to assess the structure of our patient. Overall, we would be doing a full-on patient assessment, right? We would do gait analysis. We would do a biomechanical analysis to see if all of the joints are behaving the way that they're supposed to. And we would identify those either malalignments or there's biomechanical deficiencies, and we would try to correct those as much as is possible, right? And so management is correction of the malalignments, most certainly, once you can identify them. And then the traditional treatment. So ice before and after activity, You're going to make sure they're warm because anytime you have like a tendinitis, which is essentially what IT band syndrome is, you want to make sure that they're warm, right? That they're warm, that there's blood flow going to the injured site, and you want to make sure that they're stretching. And then, of course, I think I say this over and over again. It's kind of redundant, but NSAIDs are a good thing if used in moderation. We will have some athletic trainers who just load their student athletes with NSAIDs, and that's probably not the best thing to do, right? We want our athletes to feel pain. Pain tells us that there's something wrong. So masking the pain certainly isn't the best treatment approach. The best treatment approach for any of these pathologies that we talked about is figuring out what is the issue, what's the causative factor, and then figuring out how to fix that. And if that's outside of the scope of athletic training, then we certainly will refer out and get them treatment. But iliotibial band syndrome, just for recap, in terms of the mechanism, it's typically a chronic pathology, most often caused by a malalignment. Most often, patient is going to present with pain on the lateral side of the knee as that iliotibial band is crossing. See that femoral epicondyle region and comes down to head to its attachment site onto tubercle of Gertie. I honestly equate it to, they say it feels like someone's stabbing them in the knee, right? That would be the one thing that I would look for in terms of signs and symptoms when I'm asking, what does the pain feel like? It feels like someone's taking a knife and stabbing me. Okay, then you're thinking, oh, must be IT band syndrome. So again, it occurs to the distal portion of the IT band, not the proximal portion. We'll get there when we talk about the hip. The IT band syndrome that I'm talking about right now is occurring to the lateral side of the knee, most often in that epicondyle region. Okay, so pain, like I said, is going to occur right here on that lateral side of the knee. In gross anatomy, you usually get a really good picture of the IT band. It is a thick, connective, dense tissue. And so when there's an inflammatory response that occurs there, it wreaks havoc, because what we know about the IT band is as that knee, look at this, as that knee flexes and extends, what we know about the IT band is it will snap over. Do you see this? Like kind of snap over the lateral epicondyle and condyle of the femur, and that's what's going to cause pain. If it's inflamed and if it's tightened, then that pain just increases over time. And there's not much you can do to avoid the pain, right? Because you have to flex and extend the knee. So one thing that you can do is you can kind of like put the knee in extended position, but I don't recommend it, okay? So let's talk about ways in which IT band can actually happen. Number one, it could be like a tight IT band. So a patient just walks in and unfortunately they're not the most flexible person in the world, right? And so for those patients, maybe foam rolling will work or do the trick. Deep tissue massage might work or do the trick. We can also have a patient who presents to us with this leg length discrepancy. In other words, you have one leg that is longer than the other. And so that longer leg tends to spend more time on the ground and that IT band gets inflamed as a result. You could have friction over that lateral femoral condyle. So in other words, because it's tight, as you flex and extend, as I just mentioned, that IT band snaps across the condyle, irritating it, versus actually moving across it fluidly. And then what we know about IT band is it's been linked to patellofemoral syndrome as well. And that's because both of these pathologies really sometimes have to do with a malalignment of something. Malalignment of the patella in the femoral groove, malalignment of the patella, malalignment of the knee joint, malalignment of the foot joint. It really, truly just depends. We know that people who present to us most often are going to be runners, however, or cyclists. What am I saying to you guys? It's those people who are doing what repetitively? Flexion, extension, right? If I'm a cyclist, I'm flexing, I'm extending, I'm flexing, I'm extending. Same thing with runners. That's all they do, right? To get through the running cycle. So here is IT band syndrome at its finest. And so as we look at IT band syndrome, most often you can do several different special tests, but the one that I'm going to show you is probably one of the most common. So for special testing of the IT band, there are certainly several different special tests that you can use and that you will learn in the lower extremity evaluation course. But for now, one of the things that you have to consider is the special test that's most often used, which is called Noble special test. You can see it here in this image. The patient is in a supine position and that clinician has his or her thumb over that lateral condyle, right? So just think, this is my patient, they're lying down. My hand position is such that, ready, my thumb is going to be right here and I'm actually applying a pressure. And then what I'm going to do is kind of flex that knee and extend it while applying a pressure to that IT band, right? And so what you typically will see is as you move from a flex position, as the patient is here, to an extended position is that that patient will complain of massive amounts of pain at the lateral femoral condyle, right? So that's just one special test. We'll learn multiple, but this is an easy one to use in the clinical setting. In terms of management, it's really about doing two different things. Number one, identifying what the cause of the IT band syndrome is. And then number two, fixing it. And most often the management approach, I'm summarizing. I'm not saying it's for every patient or a one size fits all, but it's typically stretching of the IT band, which you can kind of see here, and a lot of foam rolling exercises or lacrosse ball exercises over that distal portion of the IT band. Now there have been several cases where the IT band just isn't getting better or resolving itself, and there's still a lot of pain in the knee, and it's preventing the patient from being successful. And so in those cases, sometimes a cortisone injection into the IT band, or sometimes a lateral retinacular release, so surgical intervention might be required. But here are some tools to kind of help you if you encounter a patient, particularly a cross-country runner, with IT band syndrome. Okay, our next pathology is going to be quadriceps or patellar tendinitis. I'm grouping them. You can have a quadriceps tendinitis that occurs right here to the proximal quadriceps tendon. You certainly can have a patellar tendinitis or tendinopathy that occurs to the distal portion of the patellar tendon known as the patellar ligament. We typically will call this a jumper's knee, or patellar tendinitis is at least called jumper's knee. We know about both of these pathologies is that they're caused by repetitive jumping, running, and kicking sports, most often jumping sports that require you to load or go into a squat-like position. So an example of that would be basketball players who are coming down a lot from rebounds and are squatting in position or spending a lot of time in a defensive slide position. Certainly your volleyball, your defensive rows spend a lot of time kind of playing defense and grabbing the ball. So you can see it in those sports most often. Certainly can also happen as a result of a traumatic incident as indicated on this slide. So a sudden or repetitive forceful knee extension moment can also cause irritation to the patellar tendon, but most often it's going to be the quadriceps tendon that gets tugged in the knee extension moment. And so in terms of signs and symptoms, tenderness to palpation, okay? Now I'm going to say this for the different pathologies. For quadriceps tendon, that tenderness to palpation is going to occur where? Superior to the patella. And then if you're talking patellar tendon, then that's going to occur inferior to that particular patella. So location of pain will tell you which patellar or tendon is involved in the pathology itself. In terms of grades of tendinopathies, a grade 1, that patient's only going to have pain after. So they don't have pain leading up to, they don't really have pain during, but they have pain after the activity. A grade 2 is they have pain during the activity and after. So they don't have pain before, but as they get into the activity, it's painful, and after they finish the activity, it's extremely painful. And then a grade 3 is a complete rupture usually, and so they're just dysfunctional, right? There's no tendinous attachment or ligamentous attachment, so as a result, they lose dysfunction, right? What does that look like, though, functionally? If I lose function of my quadriceps tendon, oh my goodness, right? I lose the ability to flex or extend my knee because that flexor extensor mechanism is thrown off. So we hope and pray that our patients don't get to a grade 3 and that we're able to recognize the signs and symptoms of a grade 1 or a grade 2. So it becomes important as clinicians to figure out, how do we manage patients who come in with tendinopathies? Because our coaches, right, they just are like, oh yeah, it's really no big deal. It's a tendinitis. But you as clinicians can say, well, it's not a big deal now, but it certainly can progress to a grade 3 that we're going to have to now pull the athlete from for the rest of the season. So how do we manage that? You can do that with protection, right? Protection, rest, ice, compression, and elevation if it's swollen. Certainly can give oral NSAIDs. And then the biggest thing with these is like, how do we increase flexibility? Either flexibility of the muscles that they're attaching to, right? Or movement of the patella if that's the issue, right? So if we have this very stabilized patella and it's not doing what it needs to do, then guess what? Those tendons either superiorly or distally are going to get tugged. And so the question becomes, do we need to do some patellar joint mobilizations and movements to improve tendinous movement, right? So there's lots of things that we can do. I would say soft tissue is going to be key. Direct soft tissue over the tendon, right? So a cross-section massage says this is the fibrous orientation. We're actually going to go across those fibers to massage them. All right. Last but definitely not least is hypermobility. And I probably gave you the most drastic of mobility postures. The first type of posture is a genu valgum posture. That's a knock-knee posture. And we call it genu valgum. Why? Because it's placing stress on which ligament of the knee? You got it. It's the medial collateral ligament, right? We have a genuvarum posture, right? Most of you would say that that's a bow-legged kind of posture. And so we call it a genuvarum posture because why, you guys? It's placing stress on the lateral collateral ligament. And then last but definitely not least is genu recurvatum, where the patient is in a hyperextension moment. And the concern with this one is twofold. Number one, those hamstrings are extremely lengthened, right? And so are the gastrocs. And so that patient is at an increased risk. So you can see here, right, that maybe they're at an increased risk for spraining their PCL or posterior cruciate ligament, which we didn't talk about in this particular knee lecture, but we will when we get to lower extremity pathologies. Now, hear me when I say this. I know it's a lot to tackle and get through, but these knee injuries and being able to recognize them are important, in particular for those of you working football, but certainly for those of you who will work any contact sport, because the risk of your patient developing these or coming into your clinic and having these is relatively high. So I recommend replaying this, watching this, owning the actual signs and symptoms associated with it. Don't stress yourself out with knowing the special test just yet. But knowing signs and symptoms and maybe just basic ways to manage, I think will be helpful to your success in the early weeks of your clinical rotations. I look forward to seeing you sometime this week.